opportunity to be here, and thank you to everyone for just what energizing 1.5 days. I have a tall mission of keeping you awake after lunch, so I will try to do that. So no conflicts of interest to disclose. I have funding from NIH, and my plans, as you heard, is as an HIV and addiction medicine provider. I've trained as a general internist, and I've been doing research at that intersection for the past 15 years. So it's with that that I'll bring this work to you. So I started off to ground it in a story of a patient, because that is what informs the work that I do. Mateo, and I've changed some of these details to protect his confidentiality and privacy, is a 67-year-old man from Puerto Rico. He first started with heroin use at age 16, using consistently up in his 30s and injecting up to 4 to 5 bags daily. He had tried multiple inpatient programs of methadone without achieving abstinence. He was diagnosed with HIV in the 1990s, and at that time had concurrent hepatitis B and C infection. He left New York City at that time and moved to the New Haven area. In 2000, thanks to, he got started on buprenorphine with thanks to a national initiative called Beehives to integrate buprenorphine into HIV clinics. And he remains abstinent from opioids, and his HIV has consistently been well controlled. In 2013, he was referred for ongoing buprenorphine treatment to me as an addiction medicine consultant in our clinic, and he had intermittent heavy episodic alcohol use, daily tobacco use with his chronic obstructive pulmonary disease. So I think his story illustrates some of the questions we've been trying to answer. First, what is the problem? What are national strategies to integrate, or what are novel strategies to integrate addiction treatment in HIV clinics, and where do we go from here? So this is the outline for the next 45 minutes or so that we have together. So first, just to make sure everyone's thinking about terminology the same way, when we think about the spectrum of unhealthy substance use, and I credit the late Dr. Rich States for creating this term, we think about the pyramid. So at the base of the pyramid, where you have lower risk or no use of alcohol or drugs, you have at-risk or substance use disorder as you go up the pyramid with higher spectrum, higher levels of substance use and increasing consequences. And we define at-risk and substance use disorders as including unhealthy substance use. And you can see when we think about substance use disorder, we think about specific criteria for that, right, which are manifestations of loss of control, craving, tolerance, and consequences. And then for at-risk use, you can see the definitions there. I'm going to move this so I can see as you did one. Okay. I don't need to belabor this point. We've talked about this a lot today, but the global burden of disease attributable to alcohol and drug use is significant. And you can see that on the top here is alcohol use, and then on the bottom is drug use. And these are data just from the United States, but I think this is an experience that we see globally. There's a large unmet need for substance use disorder treatment among individuals who are 12 years and older. You can see here, these are data from the US that are based on national survey data that demonstrate that across age groups, less than 25% of those needing past year substance use treatment actually, there's a need among, sorry, I got that wrong. Among those with a need for substance use disorder treatment across age groups, it's up to 25%. And then you see on the left-hand side of the screen, the left-hand side of the screen, when you look again across age groups, those who received any substance use disorder in the past year, among those who had a substance use disorder treatment, had substance use disorder, those rates are low. And I just want to highlight briefly that across, when we think about different substances, opioid use, alcohol use, and tobacco use, which are the three substance use disorders for which we have medication treatment, there is a significant problem, particularly among patients with HIV. What we see here in data from New York City is that individuals with HIV were overdosing at higher rates than those without HIV infection. When we look at the HIV care continuum, across levels of alcohol use, and you see from left to right on these figures, across metrics of the HIV care continuum, you have, as alcohol use increases, patients are less likely to hit HIV care metrics that are relevant, being engaged in care, receiving antiretroviral therapy, and having viral suppression. And then we know that among patients who are on antiretroviral therapy for their HIV, tobacco use is responsible for more life years lost than the HIV itself. And we also know, including from data from the Beehives initiative that I mentioned earlier, that outcomes are improved with integrated care for HIV and opioid use disorder. And so with that background, I'm going to share with you a little bit of 3 different trials that I've been a part of for integrating treatment for HIV, integrating addiction and HIV treatment, the STEP trials, What If, and SMART. So thinking about Matteo and grounding his experience in the work we were doing, we got him started on buprenorphine. He's done really, really well. But again, the question became, what do we do about his alcohol use? So when we think about the unhealthy alcohol use, again, that spectrum that we talked about, at-risk alcohol use and alcohol use disorder, there are a number of treatment options that are available for use in HIV clinics. Again, these are the evidence-based practices that we have to implement in our HIV clinical settings. We have medications, acamprosate, disulfiram, and naltrexone that comes in oral and injectable formulation. And we have a spectrum of behavioral options that could be delivered in an HIV clinic. Brief interventions, motivational enhancement therapy, and cognitive behavioral therapy, to mention a few. So the question then became, so then the question was, answered by a large NIH initiative that funded a number of studies to ask and answer, what is the effectiveness of naltrexone in patients with HIV? Is it safe and effective for us to use in this particular patient population, given viremia and given antiretroviral therapy? And data from teams that I work with using observational data and then clinical trial data that I was a part of, and Rick and his team led, and others, there was growing data that then it was safe to use the naltrexone in HIV settings in particular. And so we then took these options, right, and thinking about these range of evidence-based practices that we had to think about how can we create a package that we can offer in HIV clinical settings to reach patients that need it to address their alcohol use. So Dr. Esterman talked about this yesterday, STEP care models. I'm going to unpack that a little bit as that was relevant for our study design. So what are STEP care models? They're a type of adaptive intervention that's flexible and responsive to patient needs, especially when a one-size-fits-all approach is not relevant. They have increasing intensity of treatment services for individuals unable to reach pre-specified treatment goals. It's been previously applied to common conditions, including hypertension, depression, and HIV. You start one treatment, the patient doesn't respond, you can try something else. It minimizes demands on patients, which is particularly relevant for non-treatment seeking individuals. Often we're seeing that patients are not looking for treatment for their alcohol use, particularly if they're coming to an HIV clinic for their regular care. It's not on their radars. These models also maximize use of clinical resources while incorporating different evidence-based practices. And so we went from the efficacy space in the research pipeline, right, where we had a number of, we knew that it was safe to provide naltrexone and other medications and these behavioral interventions. And now we wanted to move into the effectiveness space. And so we did that with the STEP trials, starting ethanol treatment and primary care trials. These were 3 parallel randomized clinical trials that were intended to evaluate the effectiveness of integrated stepped alcohol treatment for unhealthy alcohol use versus treatment as usual for patients with HIV who met one of 3 drinking categories. So if you think back to that pyramid that I showed you, we enrolled individuals who had moderate alcohol use in the context of liver disease. So even though they had lower levels of alcohol use, they had a really good reason not to. We enrolled the individuals in the middle of that pyramid with at-risk alcohol use, and those who met criteria for alcohol use disorder. We did this in 5 infectious disease clinics within our Veterans Health Administration across the United States. For purposes of today's talk, I'm going to focus on the results for the alcohol use disorder trial. And I've intended to list the papers that we've published from this work if you're interested. So this was the model. First, an individual started off by seeing an addiction psychiatrist that was brought into the HIV clinic to offer care. The focus with those visits with the addiction physician was these medications that are available to address alcohol use and decrease cravings. Then participants were evaluated at week 4 to see if they had met treatment goals, and we were looking to see if they had ongoing heavy alcohol use. If they did, we stepped them up to see a psychologist for 4 sessions of motivational enhancement therapy. Those who got stepped up at week 4, we evaluated them again at week 12 to see if they had any ongoing heavy alcohol use at that time, and if they did, they were stepped up to step 3 for specialty referral, which included whatever was available at that VA, detoxification, intensive outpatient program, and the like. We compared this model, as we talked about yesterday, there was one randomization, so people were randomized to integrated stepped alcohol treatment or treatment as usual, so one-time randomization. And we compared the treatment as usual group had a facilitated referral at the discretion of their HIV clinician. So we thought that was better than the usual care. So the provider was informed that the patient likely met criteria for alcohol use disorder, and this was in a population that wasn't already receiving treatment, and then they would be referred as indicated. So these are the participant characteristics. We had a target enrollment of 160. We did not quite meet that target. Again, these are non-treatment seeking patients who are, it's been challenging to enroll in these trials. We enrolled 128, and you can see the characteristics of this participant population. In the middle column, you have those who received the integrated stepped alcohol treatment, the 63 individuals, and the 65 who were randomized to treatment as usual. This is in a VA setting, as I mentioned, so consistent with the characteristics of the patient population served in these sites, is majority were men, they were older. You can see the distribution, they're predominantly Black. Some limited number of Hispanic individuals, and you can see that the audit C entries per week are consistent with having an alcohol use disorder. Those who were randomized to integrated stepped alcohol treatment had 33% had a detectable viral load, in contrast to those who were randomized to treatment as usual had a viral load that was 37% of those had HIV viral load that was detectable, and you can see the CD4 counts. So the question first became how many of those who are randomized to integrated stepped alcohol treatment needed to be stepped up. So again, individuals start off with addiction physician management visit. It was a series of 9 visits, I think, that they were offered over the course of the 24 weeks that continued through the duration. And 52% at week 4 met criteria for ongoing heavy alcohol use. Of those who stepped up to motivational enhancement therapy, 57% met criteria for step 3 and for the specialty referral. And then the question was, across these visits, what was the receipt of integrated stepped alcohol treatment? So if you built it, do they come? And so what we had here, I'm sorry, I misstated, for addiction physician, we'll blame the jet lag. For the addiction physician visits, it was 8 visits that participants were offered, and that occurred over the 24-week period, and that was step 1. So once you started, it was a series of visits. It was an initial visit, and then weekly visits, and then we spaced it out to bi-weekly visits, and then monthly visits over that 24-week period. You can see in the beginning, people did show up, and there was significant drop-off by the end. Among those who were offered the motivational enhancement therapy, you can see between 23 and 37% engaged in those visits. One thing I should say about this is this was an effectiveness design, so the patients were not being offered anything for coming to these visits. It was offered as treatment, so they weren't paying for it, nor were they getting reimbursed to show up. And then similarly, the HIV providers, the addiction physician providers and social workers and psychologists who are providing these interventions were doing this as part of their VA care services and not getting specifically reimbursed. So it was really consistent with real world in that way. We did not, similarly, I should just make a point, we were not giving people funds for travel, which is a big thing that comes up. So again, it was really real world. When we looked at receipt of medications for alcohol use disorder among those by group, you can see that among those who are randomized to the integrated stepped alcohol treatment, We did see improvements in provision of medications, particularly the naltrexone. We have the 3 different evidence-based medications for alcohol use disorder, and then by the time period on study here. And then this is these are the primary outcomes from this study, really looking at drinking outcomes. And if you look on the, let's see if I can, is this going to point for me now? Okay. So you can see on the x-axis you have weeks on study, and then if you focus on figure A, that's drinks per week. And at week 24, which was our primary outcome time point, we did not see a significant difference in drinks per week by group. When we looked at adjusted mean differences, on average, those who are randomized to integrated stepped care were drinking on average 4 drinks less per week than those randomized to treatment as usual, and this was a higher number of drinks, but not significantly different at week 52. When we looked at a secondary outcome, proportion with no heavy drinking days, those randomized to integrated stepped alcohol treatment, again, was not significantly different in the proportion with no heavy drinking days at week 24. But at week 52, we saw that those randomized integrated stepped care had a 5-fold increased likelihood of having no heavy drinking days compared to treatment as usual. I don't show these data, but part of what was really exciting about these trials is that we saw among those who were randomized to the stepped alcohol treatment arm were more likely to have viral suppression at week 52. So that was, for this population, that was really important and exciting as a secondary outcome. So we took these findings and went on to the next. And so some of the key lessons that we have learned was, first, as I mentioned, we did not meet our recruitment targets. So we were seeing low patient motivation to address alcohol use or enter a study. Over 50% met criteria for stepping up, so it suggested there was value in continuing to use that kind of care model. We found that this model lends support for integrated stepped alcohol treatment and HIV clinical settings and elsewhere to increase provision of evidence-based treatment. And it demonstrated a need for novel strategies to incentivize treatment. And so now we are wrapping up analyses from the follow-up trial, which we call the first trial, where we involved contingency management to incentivize participant engagement. And so stay tuned for that. So meanwhile, we've heard about the 17-year odyssey, right? I don't have to belabor at this point, but we went from having some data around, we went from efficacy, effectiveness, and then wanted to think next about implementation. And so while we were still innovating strategies to improve alcohol-related care and other substance use care, we still wanted to get into the field the things that we know work. And so thinking about the spectrum of evidence-based treatments across the spectrum of substance use that are available in HIV clinics, we talked about the alcohol, but for tobacco, which is a major killer, we have medications and brief intervention. For opioids, we have buprenorphine and naltrexone, an injectable formulation that are available for provision in HIV clinical settings in the US. And you can see the counseling options. And so we wanted to get these implemented, right? So there have been a lot of work to promote buprenorphine, but not so much around tobacco and alcohol. And we've heard a lot about different implementation strategies. The one we chose was implementation facilitation, which includes a bundle of strategies all in one, including the external facilitator, local champion, providing provider education, academic detailing, stakeholder engagement, tailoring the program to the site, performance monitoring and feedback, formative evaluation, a learning collaborative, and program marketing. And prior systematic reviews have demonstrated that this is an evidence-based implementation strategy. And so we had the opportunity to conduct What If, working with HIV clinics to adopt addiction treatment using implementation facilitation. The aims of this study were, one, to use mixed methods to identify barriers and facilitators to the integration of addiction treatments, to tailor an implementation facilitation for each clinic, to assess the impact of implementation facilitation on implementation outcomes, and then third, to evaluate the impact of the intervention on effectiveness outcomes. For purposes of today's talk, I'll focus on these first two aims. So we conducted this from July 2016 through July 2020, so the last period was interrupted by COVID. It was a randomized clinical trial with a hybrid type 3 implementation effectiveness approach. to evaluate the impact of implementation facilitation on implementation and effectiveness outcomes. So as we saw that tunnel yesterday, so with the hybrid type 3, we were really focused on implementation outcomes in this study. It was conducted in 4 HIV clinics in the US Northeast, and we used a stepped wedge design. And you can see here the sites were randomized to when they were going to receive the implementation facilitation. We had one site that we pre-specified they were going to be the last based on the timing of the transition in their electronic health record, but there were 3 sites that were randomized otherwise. And you can see we had them in implementation facilitation active period, then we had evaluation period and maintenance period. So just from some of the formative work that we did, we sought to first understand what is the readiness that individuals in these clinics reported to prescribe or refer for medications for addiction treatment by substance use disorder, and this was across the 4 different clinics. You can see there was high levels of readiness to address tobacco use, really mixed alcohol use, and most were not, the majority, 61%, were reporting to be not ready to address opioid use disorder. This was measured on a readiness scale, and we dichotomized it as at 7. So not ready was 0 to 7, and 0 to 6, and those who were ready were 7 or more. We asked about preferred model for providing treatment. We thought this was important. So this is one of my favorite questions to ask is, do you want to bring somebody in as a specialist? Are you going to have somebody trained up who's going to do this? Are you going to train everybody? Are you going to send people out? We were talking over lunch about integration of services for dentistry and medical care. So how are you going to do these things? We asked this about substance use disorder, and you can see here the responses. I won't go into too much around the qualitative findings, but we have several qualitative papers that have been published, but wanted to highlight some of our findings from the qualitative work focusing on tobacco use disorder, because that informed our next trial. And so, not surprisingly, in terms of facilitators to address tobacco use disorder in HIV clinics, it was very well recognized across prescribers, non-prescribers in HIV clinics, as well as patients, that tobacco use is a major threat to health, right? Everyone understood that that was really important. They also found a facilitator to addressing tobacco use disorder treatment was having dedicated staff for smoking cessation treatment. However, a few barriers were really notable. First, as we hear about consistently, a theme that comes up is deprioritized relative to other issues. Again, even though it was killing patients more than treated HIV. There's variable patient motivation and treatment response. And then there was concern about pills and side effects, and many patients reported that they preferred using patches over adding another pill to their pill bottle, the heavy pill burden. These are the findings from our looking at the impact of the implementation facilitation on promoting provision of medications for addiction treatment in HIV clinics. I apologize, it's probably a little busy, but it's showing the data in 2 different ways. What you can see is the forest plot demonstrating the impact of the intervention on impact in promoting adoption of each of these treatments: tobacco use disorder, alcohol use disorder, and opioid use disorder. And overall, we saw most movement for tobacco use disorder. We suspect, as you recall, most of the providers reported high levels of readiness, and so with a little bit of education, they seem to adopt that practice pretty quickly. With regards to alcohol use disorder, we have, you see wide confidence intervals. We had a delayed impact in promoting adoption of alcohol use disorder treatment, and really not a lot of movement for opioid use disorder treatment in these settings. One thing that was really important to us to inform our next step was that, when again thinking about the tobacco use in particular, we found that among those who had evidence of a diagnosis of tobacco use disorder in the health record, only 40% were receiving treatment after all of this work. So there's a huge opportunity to improve that. So we went back down to effectiveness and what can we do? And so this informed our next study that we're currently conducting, the SMART study, a smart approach to treating tobacco use disorders in persons with HIV. And this is our team. We had our kickoff meeting it was the week before COVID lockdown. And we used a couple of principles to inform the study design. First, contingency management. We use that as a strategy to really help incentivize patients who may have low motivation to address their tobacco use. Contingency management is a really strongly evidence-based practice that we know improves substance use disorder outcomes. It's the use of tangible and timely incentives for achievement of verifiable behaviors. And the goal is to motivate behavior change, especially for behaviors likely to have greater future than present reward to offset discounting of delayed rewards. So to unpack that jargon, right, that's a little bit jargony, it's the idea that people want to feel good right now and today, so you want to give them rewards for changing behavior where they'll feel better later, so they feel good right now and make that change. Again, it's beneficial in decreasing substance use, including tobacco use, and promoting HIV-related outcomes. And it was building on our team's experience collectively to apply contingency management for different substances in HIV settings. We designed our protocol to prioritize nicotine replacement therapy over varenicline, which is an oral tobacco treatment medication. They're both effective in the general population and safe among patients with HIV, but there's been limited prior studies that have compared the efficacy of NRT to varenicline to guide prioritization of one over another. And our focus group data suggested that patients may not prefer taking any additional pills, and no studies have yet evaluated the benefit of switching from nicotine replacement therapy to varenicline, so we don't know what is the best strategy. We then relied on clinical pharmacists, so why did we do that? First, we know integrated treatment models to address substance use work best. Interdisciplinary teams are the norm in HIV clinics, I think in general, across the globe, and particularly, and as well in the United States. And clinical pharmacist involvement is associated with improved HIV-related outcomes, increasingly used across health systems and community-based settings to deliver tobacco use interventions. So there's growing interest in using clinical pharmacists as part of the team to address tobacco use. Lastly, we wanted to create an adaptive and scalable intervention. So we used a smart design, and you heard about this yesterday, which is the sequential multiple assignment randomized trial, which promotes tailoring of intervention based on patient response and allows for determination of the optimal strategy to reach target outcome as well as the intervention components. We also grounded this in implementation principles and wanted to include an implementation-focused evaluation, or we included a hybrid effectiveness implementation type 1 design that was grounded in Paris, which you've heard about, and the RE-AIM frameworks. And we wanted to get perspectives of clinician and staff pre and post trial to really think about what are we going to need to do at the end of the trial when we don't have a research infrastructure to guide this work. I highlight for you here our aims, and what you can see in the orange was our original design, and COVID disrupted how we were able to conduct this, and so the original design is what is in orange, and then the modifications are what's in black. So among 320 now is our target, patients with HIV who smoke and are receiving care in one of 3 health systems in the U.S. Northeast, is to identify the optimal adaptive intervention to promote confirmed smoking reduction. We are going to look at the impact of these various tobacco treatment regimens on HIV-related biomarkers. And then, again, as we talked about on the last slide, among key stakeholders, including participants, clinicians, staff, and leadership, we're going to conduct an implementation-focused process evaluation. So this is the protocol overview, and again, this is a smart design. So if I walk you through, if you start on the right-hand side of the screen, we were enrolling patients with HIV who smoke, who had smoked at least 100 cigarettes in their lifetime, and now smoke every day or Sunday, on an average at least 5 cigarettes per day, and not actively receiving tobacco treatment. We randomized them in a 1-to-1 fashion to nicotine replacement therapy with contingency management or nicotine replacement therapy alone. And then we tailor their response at week 12, and those who respond, we continue them on treatment, and those who don't respond, we re-randomize them, either nicotine replacement therapy with intensified contingency management reward schedule, or to switch to oral tobacco treatment medication. For the tailoring variable, we're looking for self-reported abstinence, and then we're confirming that with exhale carbon monoxide testing or response of the next closest informant. And here you see the components of the intervention, so really focused on dual nicotine replacement therapy, contingency management, and oral tobacco treatment medications. In terms of the contingency management, the way we're doing this is informed by the late Nancy Petrie's work. We're using a fishbowl prize program where participants draw gift cards if they have evidence of not smoking. The reward schedule resets if they have self-reported tobacco use, were unable to confirm their abstinence, or they have an unexcused absence from the visit. They have 5 potential visits over each of the 12-week stage of treatment. And we designed this to balance regular clinic schedules versus contingency management principles. Ideally, with contingency management, you're going to have frequent monitoring of behaviors, especially things that happen every day. So there was a bit of a tension in the contingency management principles and what we can do practically. And so we'll see if it works. So in terms of our experiences to date, so you can just, here's just the timeline of the way where we are. The grant was awarded in September 2019. We launched we had our study kickoff meeting in 2020, and then launched recruitment that summer in the early stages of COVID, and then we had just published our protocol paper. I mentioned this yesterday, and then there was a varenicline recall because of contamination. So we've adapted protocols multiple times, and we're hoping to finish, as these things go, right? We're hoping to finish recruitment at the end of February, so stay tuned. Just in terms of the AIM-3, I don't expect you to be able to read all of this, but just wanted to share with you how we apply the RE-AIM and Paris frameworks, and this was informed by a paper that I had seen in the literature that was really perfect. I mentioned this yesterday during our session, that helped really inform what we wanted to do for our AIM-3. And so we're looking to collect process data as we implement the intervention and doing surveys and qualitative work as part of our study. Early on, when we first launched the trial, we surveyed providers around practices regarding medication prescribing, and this is just to, again, help us have an understanding of where are we starting in terms of the gaps that the HIV clinicians have regarding addressing tobacco use. So we know what we have to do if we bring this to another clinic after the study is over. One thing that was really has been consistent is the lack of knowledge around the importance of using dual nicotine replacement therapy. People just don't know they need to use both, and that's the best evidence-based practice rather than one over the other. And then we're in the midst of doing some qualitative work informed by the Paris framework that we've talked about to get perspectives from patients as well as the coordinators and the clinical pharmacists regarding the delivery of this intervention. So just to share a few quotes with you, and this work, I should just give a shout out to Dini Harsano and Puyani Bavishi, who have really led this work. One of the clinical pharmacists said, one of the things that I like about meeting the patient in clinic is kind of explaining to them and showing them that this study is very well integrated into a doctor's office, and that it's all a cohesive part of their care, right? So this theme of integration we talk about a lot. One participant reported, oh, it was cool, because I met the clinical pharmacist, I appreciate her very much. I thought maybe because 1 week I think I got a gum, I thought that's all I could get, and then I got some patches. Then I asked her, can I try the inhaler? And I was able to get that too, so I was grateful. And it really spoke to the facility of the clinical pharmacist and really working with the participant. This participant should have been offered both forms up front, and hopefully that was the case and maybe declined. And part of our protocol was make sure you continue to engage the participants and work with them to get them on NRT. And lastly, it was difficult because I went to smoke in between. This is talking about having to do the verification with the exhale carbon monoxide testing. But I know if I smoked in between that it would tell on me. So I did. So I white knuckled it not to get a chance to pull a $100 gift card out, a $50 gift card out, a $25 gift card, a $5 gift card out. It didn't matter how much. I knew what I was going to do with the gift card. I knew I wasn't using it to buy cigarettes. I knew that I was using it to help maintain my household. So I think this was, really speaks to the benefits of contingency management and how the external verification is really important for motivating behavior change. So lastly, just a very brief comments on current and future directions, informed by, just to circle back to Matteo. So he had gotten his buprenorphine treatment for his opiate use disorder. We've gotten him with just ongoing counseling, behavioral intervention to reduce his alcohol use. And now, fast forward to 2023, his HIV is well controlled. His opioid, he's been abstinent from opioids and very low dose buprenorphine. He's decreased his alcohol use. He's stopped smoking. But now he's challenged by his obesity. He's 250 pounds with a BMI of 37 and metabolic syndrome, low back pain, and knee pain. So I think as we've talked about, there's really the benefits of and the success of having treatments available for patients with HIV and their substance use disorders. Now we're challenged to address their other non-communicable diseases, which is really, it speaks to the success of treatment. So in summary, implementation science principles are useful for guiding efforts to improve adoption of what works. There's an ongoing need to cycle between efficacy, effectiveness, and implementation designs, right, as we're innovating and trying to get out what works, but really continue to improve it. It's never good enough. New efforts can be directly informed by mixed methods to inform tailoring of the intervention strategy to stakeholder and contextual needs. And then with the success of HIV and addiction treatment, there's growing need to enhance primary and secondary prevention of medical comorbidities. So lots more work to be done. Thank you. I neglected to acknowledge amazing team members. Dr. David Feline has been my primary mentor through this journey, and others you can see here, Amy Justice, Lynn Feline, Patrick O'Connor, and Gail, and the late Marjorie Rosenthal. You can see a huge team here, including Dr. Esterman. So thank you.
Thank you.
I'm going to take any questions.
Yeah. Do we have any questions?
First of all, congratulations on a tour de force. I want to just make a couple of comments about this presentation to sort of think, for you all to sort of prime to think through what's happened. So the storytelling was good around the patient. What's interesting is that each study worked to build upon the next set of questions, and that is really an important part of your work, whether it goes from the efficacy to the implementation trial. So it sort of represents the sort of the natural history. One of the things that I would be really thrilled with other folks to sort of think about is to really consider, you know, we've talked a lot about the HIV treatment cascade, but all of these non-communicable diseases are going to be the things that are going to take our patients to heaven. And so this is really, really important work. One of the things I want to sort of ask about with all of this is that, you know, you've sort of taken the sort of platform of substance use disorders, and really Matteo sort of represents these other non-communicable diseases. I mean, I know that, you know, it's HIV and addiction medicine, which is your sort of, you know, similar phenotype in terms of training and interest, but do you have an intention to take it into other NCDs? I mean, whether it's obesity or any, which is in some cases related to, you know, addiction as well and stuff.
Yeah, so kind of long-term passion of mine personally, and the space I want to build is physical activity interventions, and thinking about how can we build that into the work we're doing. So I think that's, you know, primary prevention for mental health, medical conditions, and the like. So.
Is there any evidence about superiority or inferiority about nicotine replacement strategies, gum versus inhaler versus patch, or is it just individual preference? There really isn't a difference.
Yeah, thanks for asking that, Sven. So my understanding of literature, and I'm really fortunate to work with Steve Bernstein as MPI on this study, who's the card-carrying tobacco expert, but generally speaking, dual NRT, so my understanding, long-acting with any short-acting option is best, and tailoring the preference of the short term is fine. But you want to have the long-acting nicotine replacement therapy, so it's really, if you think about the way we treat pain, right? You give long-acting treatment, so it's in the system to prevent the cycles of which craving and withdrawal, and then you have the short-acting to help with breakthrough. For patients, you know, who, for example, they don't have teeth, right? And that happens for our patient population, right? So then the gum is not going to be an option. Some people don't like the lozenge, some people really like the inhaler. And so that works well, so they have something for their fingers to hold. And yeah, NRT and varenicline both really first line compared to bupropion, which is not as effective.
Second question, in the SMART trial, I think your definitive endpoint is the answer to the question, I'm not having been a puff for a week.
Right.
And then it's confirmed with your biochemical evaluation. But of course, clinically, we're very interested in reduction of smoking. I mean, if you go from a pack to a cigarette a day, you know, you've made a lot of progress. What data are you going to get on that as an intermediary or secondary outcome?
Well, so it's such a timely or relevant question because of the change in sample size. We changed our primary outcome. So because of COVID and COVID delays and the way that patients were flowing through the clinic, we are not going to be able to meet our target sample. And so we ended up changing our primary outcome in consultation with NCI and with our DSMB. So our initial outcome had been to get people to look at abstinence, and that is the target for the contingency management program. But we have changed that now, so we'll be looking at reduction. The challenge with reduction is we're using exhale carbon monoxide testing, and so we don't have, that gets short-term tobacco use as opposed to cotinine and abasin. So in the next trial, maybe we would look at that. So we don't have anything beyond self-report to confirm the reduction in tobacco use. A secondary outcome will be now abstinence based on self-report, either exhale carbon monoxide testing, and then we added the next closest informant because of COVID, because of the telehealth visits that we incorporated and the like. So, but we agree with you, and we had to make that argument to NCI that less is more and not, anyway, it's very interesting. So agreed.
And a mischievous question, do you believe that alcohol consumption and adverse health is a J-shaped curve or a linear curve? Because for I don't know how many decades, they've said that a drink a day could be a good thing. And now very recent data says that 1 drink a day is worse than 0 drinks a day.
Yeah.
So which is it? We're in Malaysia. People want to know. I don't know, of course.
Yes. So I think if you want to really do that, I don't think drinking 1 a day is healthier for you. That's my
Okay.
Yeah.
So you're a dose response person.
I don't know how we are on time. Are we okay on time?
I think it's our last question.
Thank you so much. I have 2 questions actually. So my understanding of the US healthcare system is that it's based on an insurance scheme and that people would usually have to pay for treatment, right? Even though you're on an insurance plan. So looking at the different treatments that were offered, was there any barriers towards, for example, a person couldn't pay for such and such treatment even though it was, according to the plan in the research? That's question number 1. Number 2 is that would you have any plans to look at vaping, in consideration for this? Thank you.
Yeah, great questions. I should have answered your first question when I responded to Sten as well. So part of the decision that we saw in which form of short-acting NRT got used was based on which was covered by insurance. So you could get the inhaler with a prescription more easily and it would be covered, as opposed to the nicotine replacement with the gum and the lozenge was not covered by insurance. And so we saw that many patients were not getting it. We were able to advocate in the past year to get it added to the formulary for Connecticut patients with HIV. So that has made it more accessible, but we are tracking that. And this is again a real world study, so we're not giving patients the treatment in their hands. And so part of what we're looking at is actually, if patients are prescribed it and willing to accept the prescription, right? Because even though they sign the consent doesn't mean that they actually want it when they meet with the clinical pharmacist. And actually if they pick it up and start taking it. And that is, we have seen that that's been a barrier. So thank you for that first question. The second question with regards to vaping, so we are evaluating vaping behaviors but you're not, that's not part of like our outcomes. And if you're exclusively vaping, you're not eligible for participation. Thank you for that question. Oh, do you have a follow-up? Okay. Thank you.
All right, thank you so much, Professor Jennifer. Can you join me in thanking her? Thank you. All I could think of during that talk was that you probably forgot Malaysia as one of your sites, because I think we are in desperate need of it. So after this, we are done for the lectures for today, and most of the sessions this afternoon will be interactive workshops as well as a skills building session. So right after this, we will have two interactive workshops. The first one would be here in this room, which would be on promoting community engagement in implementation science with Professor Stan Vermund and Dr. Noor Afika binti Muhammad Saleh. And for those who are interested to attend Track B workshop, which will be held in the Maple Room. So if you kind of follow the corridor outside around the swimming pool, you'll reach the Maple Room. And that will be on designing your study and methodological and sample size considerations. And the facilitators will be Professor Denise Esserman as well as Professor Rafsa Ahmad Zaki. So following that, we would have a short tea break for 15 minutes because I'm sure you guys are starving again. And then we would have the final skills building session, which track A, as you can imagine, would be held here again, which will be on the promoting change in criminal justice settings through implementation research with Professor Sheila Shenoy, Prof. Rick Altis, as well as our Director General of Health, Muhammad Razi Abu Hassan. And for track B, which would be the session on Ask the Experts, Implementation Research Consultation, which all of you have written your questions for, that would be held in the Maple Room. And that would be with Professor Rafsa Zaki, Professor Luke Davis, and Professor Jennifer Edelman. So if I could just encourage all of you to make your way to the different rooms, and then we will get started. Thank you very much.